Welcome to Urology Grand Rounds. This morning, we have presentations from our sub-Is, Yale Urology. First, we're going to have Dylan Heckscher, who's going to be talking about assessments of technical skill and coaching in urologic surgery. And then we're going to have Olawoyin talking about BCG Immunotherapy for urothelial carcinoma of the bladder. Each of our speakers will have approximately 20 minutes to present, and then we could have 10 minutes for question and answer, but we'll try to keep it on time so everyone has time to present.
Well, good morning, everyone. As mentioned, I am Dylan Heckscher. I had the pleasure of doing a sub-I here at Yale just back in July. In addition, I've been serving as your Quality Improvement Fellow since late April. In that role as Quality Improvement Fellow, I've had a lot of opportunity to think about QI. And so as tried as it is, I've come to realize that it's mostly about assessing quality and achieving improvement. So to that end, today I'm going to be talking about assessments of technical skill as a means of assessing quality, and then coaching in urologic surgery as a means of improving quality. So the objectives of this talk today are going to include discussing various means that are used currently to measure surgeon quality. I'll also assess the data that relates technical skills to patient outcomes, some of which is quite recent. In addition, we'll be describing a new system for technical skills rating and for assigning ratings to technical skills. And I'll discuss data on coaching for trainees and attendings. So how can we meaningfully assess surgeon ability? Currently, we primarily use a few different methods, including things like process measures and skill proxies, but the most prevalent and most well-respected one is patient outcomes, because ultimately what we care most about is that's what we care most about as healthcare professionals. There is a new area of exploration, which is subjective skill ratings, and that is going to be some of what I start this discussion with. What part of the reason that we want to focus on novel methods is that our current methods are primarily retrospective. So our main method of assessing and addressing surgeon quality currently are based on individuals retrospectively identifying examples of morbidities and mortality. And this has a number of different pitfalls. There's different skill levels between the observers and the attending surgeons. It could be a PACU nurse, it could be a resident. It's highly subjective what cases get submitted. In each of those cases, harm has already been done. And as a result of that, the assessments and suggestions that come out of these discussions are typically narrow in scope and focus specifically on the specific harm that occurred. As an example, I'd like to draw your attention to the figure here, which is a portion of our Urology Quality Assurance and Improvement Committee reviewer form. As you can see, there's truly only two categories for the reviewer to select. There's either no issue or there's some issue. And it doesn't allow for feedback that isn't immediately relevant to the case in question. And because it's linked to potentially disciplinary and administrative proceedings, reviewers may often take great care to avoid overt criticisms that may be taken personally, and the attendings who are undergoing review may feel a degree of defensiveness that makes it difficult to integrate certain elements of the review into their practice. So the alternative would be certain kinds of proactive approaches, which have the benefit of assessing skills absent identified harm. So that would be, as an example, rating technical skills before there's any morbidity and mortality event. It offers an opportunity for critique of one's surgical skills after residency, which is otherwise difficult to come by, an opportunity for skills evaluation in a non-judgmental setting, skill sharing across institutions and between attendings, as well as the diffusion of innovation. There's been a number of different methods developed to put a number on technical skills, which was the primary example of this proactive approach. OSATS is probably the most widely adopted. It's now over 20 years old, and there's been a number of various means or attempts to validate it. This is just a small selection of some of the data, which shows that it reliably, it's a good method reliably of rating surgical trainees. They reliably improve their scores over time, and the scores can be used to accurately distinguish resident training level. And in each case, OSATS has been shown to have high inter-rater reliability, which makes it a useful tool for technical skills rating. Probably the most important recent study that's come out about technical skills ratings in urology came out of the Michigan Bariatric Surgery Collaborative. Now, in this study, they took 20 bariatric surgeons and examined 10,000 of their cases retrospectively for patient outcomes. In addition, they had each surgeon submit one representative video, which was then rated by their peers on a series of different metrics, which I'll show you in just a moment. These ratings were then used to stratify the surgeons by quartile, and different data was gathered by each quartile. So here you can see the three quartiles, well, four quartiles, but the three sections the surgeons were divided into. One thing I'd like to draw everyone's attention to is the fact that the summary rating for even the lowest performing quartile still indicates that the peer surgeons thought that these surgeons were above average. They were told to treat a 2.5 as the rating of an average practicing attending surgeon, and even the lowest performing quartile in this bariatric surgery collaborative had a summary rating of 2.9. In addition, the other things I'd like to note here are that the best performing quartile had a substantially higher surgical volume, nearly threefold higher than the lowest performing quartile, and they operated substantially faster, with the lowest performing quartile taking nearly 40% longer for the same procedure. The study then went on to use the data from their 10,000 prior cases to compare surgical outcomes between these quartiles. Now, as you can see, the rates of all complications were nearly threefold higher for the lowest performing quartile, based purely on technical skills, as well as the rates of reoperation, readmission, and emergency department visits. There are several key takeaways from this study, some unsurprising. For example, surgical volume and technical skill ratings are closely correlated. Career length alone, interestingly, is not correlated directly to skill. Complication rates and operative times, two things we care deeply about, are very closely correlated with these independent ratings of technical skill. And in addition, these differences in peer-rated technical skill were significant even when comparing highly skilled surgeons. So it wasn't just the absolute worst surgeons and the absolute best surgeons. It was, you know, a cluster of high-quality surgeons you could still differentiate on the basis of technical skill. There are a few potential areas of bias or confounding error in this study. All of that data is correlative. It's been shown by a number of different studies that both surgical volume of a hospital system and operative duration are independent predictors of outcomes. So it could be the case the technical skill causes reduced operative times and improved outcomes, but it may be the case that these variables are confounding each other. For example, it could be the case that a high volume hospital is faster because there's better assistance, and better assistance, better PACU nurses, better aftercare also equals better outcomes. It could be the issue that the central issue here is time, and that surgeons who operate very quickly are inherently viewed as more competent by their colleagues, and the rapidity of their surgery also independently influences complication rates. That said, the idea that technical skills is correlated with patient outcomes does have a high degree of face validity, so it's at least somewhat valid. That study leads to a number of questions for potential future exploration. If technical skills affect patient outcomes, what can we do about it? Can we move surgeons individually from one quartile to another? Can we shift the bell curve of quartiles to the right? Can we move it as a whole? And if we shift it, how do we establish minimum standards then of technical competency? If everyone is improved, we can't say that the lowest performing surgeons aren't doing well enough simply because there inherently has to be a bell curve. In addition, it does raise a sort of interesting idea that we could use these kinds of minimal technical skills evaluations in residency training. You'll say, you know, once you've reached a 3.5 technical skill rating in a given surgery, you've signed out of that surgery and now can perform it alone. But that's a topic for another time. So what can we do about it? And this is where my talk is going to transition to the implementation of quality improvement. The idea of surgical coaching has come out recently. It was popularized back in 2011 by Dr. Atul Gawande, and is really closely related to this idea of technical skills. Dr. Gawande's chief revelation was really that when he was a highly skilled tennis player, and he noted, I'd paid to have a kid just out of college look at my serve. So why did I find it inconceivable to pay someone to come into my operating room and coach me on my surgical technique? Even the best tennis players in the world have coaches, and those coaches are definitely not as good at tennis as they are, but they are still capable of making valuable observations about the player's game. Similarly, a surgeon who is closely related, may not be a specific expert in the specific surgery, is still likely capable of making useful observations about a surgeon's technical skill and decision-making. Now, as this is a relatively new area of study, there's only a few major reports on the impact of coaching. One came out of Boston, actually closely related to Dr. Gawande's Ariadne labs, and that's the SCOPE trial, Surgical Coaching for Operative Performance Enhancement. In this case, they took 46 surgeons from 4 academic centers, split them in half, had one half coach the other half. Each coachee had 3 coaching sessions with one partner over the course of the year, and they were rated at each coaching session and before and after the end of the study on technical and non-technical skills. The outcomes were interesting. There was no change in scores across the sessions from the beginning to end of the study. The study did not measure objective patient outcomes between the beginning and end, so we don't have that data. Interestingly, surgeons did report significant subjective improvements in patient care, as well as patient personal well-being. But there are some potentially biasing factors here. First and foremost, the surgeons all knew each other. And so the sort of collegial relationships that occurred here and the unblinded nature of the study meant that, somewhat unsurprisingly, the ratings of surgical skill clustered near the top, which offers little room for improvement from the beginning to the end. In addition, those same social relationships may have made it difficult for surgeons who were critical of the coaching to say so at the exit interview, and they may have then reported subjective improvements that they didn't really feel. Another study of coaching, this one came out of the Michigan Bariatric Surgery Collaborative as well. This was called Video Analysis of Peer Coaching in Bariatric Surgery. In this case, they took 15 coaches who were the highest performers in their group. They had 26 coachee participants and 25 non-participants whose data they looked at as a control. In this case, they analyzed pre and post-intervention outcomes for 2 years prior to the intervention, a 1-year intervention, and then 2 years post-intervention. What they found was that there were no significant changes in surgical outcomes pre and post-intervention. Risk-adjusted overall complications and overall complications rate were unchanged. Interestingly, there was a change in surgical operative time pre and post-intervention with statistical significance. This is especially interesting given some of the data I discussed earlier that shows that operative time is independently correlated with reduced complication rate, but in this case, apparently that did not manifest. The next question is, does coaching not work at all, or can we improve coaching? This may just be growing pains. Perhaps the reason why coaching didn't work well in those 2 cases is because it's a relatively new concept in the field of surgery, and we may just not be very good at it yet. Coaches may need training on coaching. Coachees may need to be receptive and learn how to integrate other surgeons' feedback into their practice, and that culture may not be there. So the same group out of Boston that conducted the SCOPE trial also came up with some key implementation recommendations going forward for coaching programs. So hopefully we'll see in the future if those actually result in meaningful differences in patient care. Now I want to transition to discussing a national program, a product from Johnson & Johnson called CSATS, which integrates both the aspects of technical skill rating with certain types of coaching. In this case, it's a crowdsourced assessment of technical skills. Surgeons will upload recordings of individual laparoscopic and robotic surgeries, and they'll be rated by other surgeons on a variety of different technical skills metrics. These rating tools have been validated primarily for inter-rater reliability. They've not been validated in the same way as the Michigan Bariatric Surgery Collaborative for actually patient outcomes, but I suspect they will be doing that going forward. After these ratings are given, observers also provide qualitative feedback and recommendations to the surgeons who submit those videos. This is an exciting opportunity pipeline for a number of reasons, beyond simply the integration of surgical coaching for the attendings. Building a video library like this may be extremely useful for trainee education. I'll touch on that in just a moment as well. Surgeons may build video portfolios, which can be useful for a variety of reasons. They can use them to lead video-based master classes on specific surgeries. Employers in the future may benefit from these video portfolios or even require them for hiring decisions and credentialing practices. One benefit of this is that you could potentially bypass the traditional credentialing practice if you see that someone's video portfolio demonstrates that they have sufficient technical skill. One more controversial aspect of building a video library like this is certainly a risk management perspective. Having a definitive record of what occurred in the surgery in the form of a video, it has its advantages and its disadvantages based on the specific outcome. It's worth noting that these ratings, coaching, and recordings may fall under peer review protection. So there's some additional other future directions for CSATS in particular, as well as rating of technical skills. One could integrate considerations of surgical skill into research going forward. There's a great deal of inter-surgeon variability in technical skill, and perhaps having a numerical definition for each surgeon's skill could be used as a means of avoiding confounding error in future studies going forward. In addition, as previously mentioned, there are a number of studies out there showing that video-based learning can accelerate the surgical learning curve for residents. And so perhaps building a video library, as one would do with CSATS or other methods, could be used then to help trainee education. In summary, I hope I've given everyone here a reason to consider the benefits of technical skill ratings, and I hope everyone is excited about the possibility of coaching in the future as I am. And with that, I'd like to open the floor to any questions.
Okay, does anyone have any questions at this point?
I did, Dylan. I thought that was a great overview of a really complicated and somewhat controversial topic. But I think as the group knows, we are in kind of the final stages, hopefully final stages of negotiating with Ethicon around bringing CSATS to our center as a pilot in urology. And we also invited gynecology and general surgery to participate. This is being led by Jamie and Dylan. This really kind of, I think, a really exciting time. We were able to secure funding through Jamie's work with MCIC, our captive insurer, as well as through Periop. So we're working with supply chain on trying to get the final aspects of it negotiated so we can launch hopefully this year. But Dylan, I was wondering one thing. In that Michigan Bariatric Surgery video study, they had like a decade's worth of data from their collaborative.
Yes.
But they only looked at one video. And if I remember correctly, what they did was they told the surgeon, can you submit like what you think was your best video over the past 6 months or something like that? So why do you think one video from one operation correlated to their outcomes over a long period of time? Do you think like technical skill is something that's durable? Can it vary from one operation to another? Like, and if it's durable, does that suggest that it's going to be hard to, like, is that a reason why it's hard to change?
That's a really wonderful question. I think there are elements of technical skill that are durable. As I mentioned, there's always going to be a bell curve of technical abilities. Some surgeons are naturally better at certain aspects of surgery than others. I think the real advantage of submitting one representative video in this case was probably surgeon buy-in. If you feel like this is a representative example of your best work, then you may be more invested in hearing feedback about how to improve your best work. But to your direct point, I suspect it is an issue of durability. I wonder what the actual difference. I think it would be an interesting study to take the lowest rated, have each surgeon ask for their worst video example as well, rate that, and then compare that rating to the best video and see what the difference is there. Study for another time.
Hey Dylan, this is Isaac Kim. Again,
Kim.
appreciate it. Enjoyed your talk. So, quick question of the CSATS. And my impression of CSATS is that it's more of a ratings type of a platform. So, the coaching really involves, someone being able to take a look at it and be able to actually recommend some sort of intervention. Does the CSAT, that, as you know, does it actually provide that feedback to the some sort of a specific concrete feedback that the surgeon can use to improve him or herself?
Yes, absolutely. So you're right that the primary role of CSATS at the moment is building a video library and providing a technical skill rating system. However, those observers, as they are trained surgeons as well, are asked to provide qualitative feedback at the same time. They, in theory, are not just going to say, your tissue handling was a 2. They may say, in the future, it would be beneficial for you to work on certain types of efficiency and certain kinds of instrument handling, for example. So it's not the kind of in-depth one-on-one coaching that these other 2 studies were looking at, but it is an opportunity for direct feedback on these observed surgeries.
Thank you.
This is Michael Sieve. At NYU, we used CSATS, and every resident was in the program. Like Dylan was saying, most of the feedback was not actually quantitative, where we were rated on a number scale. It was mostly comments such as nice anastomosis, try using both hands, too much tension, and things of that nature.
Yeah, I think there's some variability in its implementation. There are 2 quantitative scales that they are at least claimed to be using. We'll see at our institution what we derive the most value from, I think. But either way, I think the direct feedback is there.
Dylan, great presentation. This is Dr. Cavallo. And just to add to what everyone was mentioning, there are different modules that institutions can purchase from CSATS. What we are looking into is both qualitative and quantitative. There are validated instruments called gears and goals for laparoscopic and robotic procedures, and they implement a crowdsourced scoring. So they have found that a critical mass of trained individuals looking at anonymized videos and using these validated instruments can provide an objective way of assessing technical skill. There would be that element, but there would also be an element where segments of operation videos can be sent to an expert in the field, again anonymized, for the qualitative feedback that Dr. Shi was referring to. So both elements would be sent back to the surgeon to be reviewed and implemented into their practice. And we can also look at trends over time and figure out who needs or who would benefit perhaps from more hands-on in-person coaching opportunities.
Dylan, this is Leslie Rickey. I thought that was really interesting. And Jamie, thanks for those clarifications also. I have one comment and one question. One, I think, and this is, I think speaks to what people have been bringing up. I think one of the, OSATS was around for a long time, and they could show differences in scores that the residents had at the end, but I think they had difficulty showing that translated into being a more successful surgeon or, all those different measures. So I think one might be the approach, but the other part is the metrics, what are we going to use? And yes, you can show some things like in a short amount of time, but other things take longer time to manifest. So I think the metrics have gotten better, because it was always interesting to me, like, why isn't this translating to be a better surgeon? And it's because I think what is a better surgeon is up for discussion, to some extent. Clearly complications in time and all those correlations that Dylan showed, I think are important. My question is, I think when we hear things like the tennis coach analogy and things in different fields, they make sense. Like they make sense, and all of us want to be better. Like that's what we spend our lives being, is trying to be better. But there is some inherent discomfort, I think, with the coaching in surgery. And I'm not 100% sure where it comes from. I don't know if there's been focus group work around this, but I think it's worth doing, because I think normalizing is a nice word, but how you do that is a whole other kind of exercise. I think some of it is medical legal. And and some of it might also be some concern about, like, is this going to harm your referral base? Like, if all of a sudden you're seen as this person that needs help and people don't want people that need help operating on them. Again, I'm not saying that's right or wrong, but I think there's just some discomfort with it that has to be overcome on an individual surgeon from institutional and societal levels in order for this to really become accepted as normalized. And so I just don't know if anybody's doing work around that right now.
Absolutely. I think there are some medical sociologists who are working on various, mostly focused on sort of achieving buy-in on quality improvement in general. I suspect as coaching gains in popularity, there'll be more work done towards creating culture shifts within departments. But it does ultimately just require that everyone be willing to accept criticism in pursuit of improvement. It's a little tricky, of course, because there's a great deal of variability in how different surgeons practice that isn't necessarily correlated with any changes in patient outcomes. And that's where it becomes difficult to actually say who's doing one thing better or worse. To your medico-legal question, I'm just going to go to one of my appendices here. There are statutes that in theory should be protective against the use of this data or these coaching examples to sue or otherwise harm a provider. I would expect then that the sort of confidentiality of these coaching sessions would be paramount, and would also protect a surgeon's referral base in the same manner as it would protect them from medical legal.
Leslie, a lot of the work that Jamie's been working on in order to get CSATS out is to figure out how to roll this out so that it isn't perceived as like a punitive measure or something like that. And through legal counsel, applying it broadly, similar to how we do M&M or the peer review. It's not like certain people are subject to M&M review. Everybody is subject to M&M review and has the opportunity to share. And so if this product or this opportunity is applied broadly to everyone, it's not seen to be a remediative effort, but more of a peer review effort to improve across the board, and would be under the protections to some degree that M&M would be.
And to add to that, Dr. Ricky, thank you for bringing up those great points. There are process measures certainly that we intend to measure, things like operative time, patient outcomes, both in the immediate postoperative period and long-term. But there's also specific ones. So for instance, if we are focusing on anastomoses and getting feedback about how an anastomosis is performed, and then looking at the leak rate or bladder neck contracture rate or incontinence rates after that specific intervention for a segment of a case, then we can correlate them more strongly. With regard to the legal and risk questions, this is an avenue we definitely want to and have been investigating very thoroughly, because we certainly want to look at every aspect. As Dr. Munamedinia had mentioned, when it is done in a systematic and peer review fashion, there are protections in place that we want to ensure, along with our colleagues in risk management, are applied to CSATS, and that is how we intend to do it. It matters how the videos are treated and what is done with them over time. If they are treated as a part of the medical record, it is something that can be subpoenaed. If they are treated as part of peer review, which is how we intend to use it, it will fall under peer review protections.
I know we have to move on, but there's one last comment about the risk aspect of this. I think it's no mistake that MCIC, our captive insurer, is the group that is willing to fund this. I think the idea is that if we all get better as surgeons, we raise average performance, hopefully there are fewer bad outcomes. And if there are fewer bad outcomes, hopefully the overall risk of a suit goes down. And so I think that's their motivation, which is it's pretty easy to draw the conclusion. I think the challenge, like you mentioned, Leslie, is getting everyone to realize, and not just our group, I mean, truly every surgeon to realize that we're not all above average. And, because every single one of us does. There's aspects of every operation that we could all get better at. And I think this is kind of a first step in at least identifying what those things are, bringing some sense of reality to your performance. And then what happens with coaching afterwards, I think an impact on patient outcome is still uncertain.
I absolutely echo on what Dr. Kenny said, because again, I said I've done over 2,100 cases of robotic prostatectomy. I'm still tweaking my technique, so we're all still learning. So I think throughout our career we have to continue to learn. So again, thank you.
All right, so Dylan, wonderful job. For the sake of time, I don't want to take away time from Olamide. So Olamide, Olawoyin is going to be talking about BCG immunotherapy for urothelial carcinoma of the bladder.
Well, thank you so much for the introduction. And thank you all so much for being here today. So today I'll be presenting on BCG immunotherapy for non-muscle invasive urothelial carcinoma of the bladder. And so in terms of my outline, I want to talk about the historical background, discuss the risk stratification of non-muscle invasive bladder cancer, go over the current AUA non-muscle invasive disease practice guidelines, and then briefly we'll talk about the mechanism of action of BCG and finish the talk with alternative therapies for non-muscle invasive disease. So I'm a big fan of history, and I thought I wouldn't do this talk justice if I didn't talk about some of the historical background. So BCG was actually created by Dr. Kalmit, who is a physician, and Dr. Guerin, who is a veterinarian doctor. And its initial intention was for use for vaccination against tuberculosis, and it's still being used across the country in countries that are TB endemic. And I actually have a picture of my arm showing the scar from the BCG vaccine that I got. And so I thought it was very interesting once I learned that BCG is also used as immunotherapy for bladder cancer treatment. So a little bit of a walk down the memory lane. A little over 100 years ago, the making of BCG for treating TB was started. And then in 1928 was when the first discovery was made that tuberculosis lesions was actually more than twice prevalent in cadavers without tumors compared to cadavers with tumors. And then in 1959, this was when the first work surrounding the use of BCG for protecting against cancer development began. So mice receiving BCG for 7 days before tumor challenge were shown to be protected from developing cancer. And then in 1970, they realized that analysis of 287 death certificates revealed that leukemia incidence was higher in non-BCG vaccinated children. And then in 1976 was when the first work for use of BCG for bladder cancer came to be. And this work was mostly done by Dr. Morales, who showed in a study that there was a significant decrease in terms of patients with tumor recurrence pre-BCG versus post-BCG, with majority of the patients eventually having no tumor recurrence. And in 1990, the BCG for intravesical use for protecting against non-muscle invasive, for treating non-muscle invasive bladder cancer was approved by the FDA. And I think it's also important to note, given the current COVID-19 pandemic, that this was something that was studied extensively at the height of the pandemic to see whether or not BCG vaccination can protect against COVID-19. And this was mostly because the rate of COVID-19 incidence was lower in regions with high rate of BCG vaccination. This has, however, been shown to not really be much of anything. So shifting gears a little bit, I want to talk about the risk stratification of non-muscle invasive bladder cancer. And first of all, I want to define what non-muscle invasive bladder cancer is. So this is essentially any bladder cancer that's between the mucosa as well as the superficial muscle. So starting from carcinoma in situ, and then TA disease would be disease that affects the epithelium, and T1 disease will be disease that affects the lamina propria. The initial nomenclature from the WHO in 1973 really graded these as papilloma, grade 1, grade 2, grade 3. However, this proved to be a little bit confusing because grade 2 disease was very murky. So the nomenclature was updated in 2004, and now we essentially use this new one where we describe as papilloma, papillary urothelial neoplasm of low malignant potential, non-invasive low-grade as well as non-invasive high-grade papillary urothelial carcinoma. And so the majority of my talk today will be focused on high-risk disease. But before doing that, I wanted to talk about the AUA risk stratification for non-muscle invasive disease. So AUA describes the low-risk disease as low-grade tumor, so solitary TA less than 3 centimeters, So anything within the, mainly affecting the epithelium, as well as papillary urothelial neoplasm of low malignant potential. And then Irix disease is really defined as high-grade T1 disease, so such as the ones affecting the laminar propria, any recurrent high-grade TA, greater than 3 centimeter disease, any carcinoma in situ, as well as any BCG failure in high-grade patients, and of course, any lymphovascular invasion, as well as prostatic urethral involvement. And so what are the current AUA practice guidelines for treatment? The most important one will be that in high-risk patients, the AUA is recommending that patients with high-grade T1 or high-grade or high-risk TA urothelial cancer should definitely be administered a 6-week induction course of BCG. And this is one of those things that have really strong recommendation. Evidence for this initial therapy came to be from several studies, one of which is the meta-analysis that was published in Journal of Urology in 2006, showing that in several studies, patients that got BCG versus no BCG by TURB, following TURB definitely did a lot better in terms of tumor recurrence compared to the patients that didn't get any BCG therapy. And a more recent study showed that there is an improvement in terms of overall survival for patients with BCG therapy compared to those that did not get BCG therapy. For maintenance therapy, the guideline states that a patient with intermediate risk should be considered for maintenance BCG for 1 year as tolerated. And then in high-risk patients, they should be continued on maintenance therapy for 3 years. And what exactly is the regimen that is being followed in terms of standard therapy? So the SWOG protocol mainly is where a lot of the study came from. And what they were able to describe was that the main benefits comes from treating patients 2 to 6 weeks after TURBT with an induction dose, which should be 6 doses given weekly. And then you wait a period of 3 months before starting the maintenance therapy. So maintenance therapy is 3 doses given at month 3, month 6, 12 months, 18, 24, 30, and 36 months. And evidence for this came from the SWOG protocol, the SWOG trial, like I mentioned earlier. And they were able to show that risk-free survival was 76.8 months in patients that got maintenance therapy versus 35.7 months in patients with no maintenance. And similar data was shown in terms of worsened free survival, with patients on maintenance therapy definitely doing a lot better. And so there's been a lot of talk regarding, is there any importance in 1 versus 3 years maintenance therapy? So the EORTC trial showed that basically concluded that for intermediate disease, there really wasn't any benefits for 1 versus 3 years maintenance therapy. However, they were able to show significant, to some degree, significant effect for patients with high-risk disease when they were treated with 3-year therapy for full dose. And with that, I want to talk about the mechanism of action of BCG. But it's important to first note that for as long as BCG has been around for over 100 years now, we actually don't really have much of an answer as to how it works. But I think with new advent understanding of how immunotherapy works, there's a lot more new proposed mechanism of action for it. So the current working mechanism of action is that it really takes advantage of the immune system for killing cancer cells. And the induction therapy really takes advantage of the innate immunity, where there's attachment of the BCG to urothelial cells. This creates a cytokine storm, which then induces an effect against killing cancer cells. And then with repeated instillation intravesically, we're able to see more of an adaptive response, which triggers a Th1 as well as a Th2 response, which then produces CD4 as well as CD8 positive lymphocyte and production of more cytokines. And with continued maintenance, we're able to take advantage of the adaptive immune system, which continues to cause killing of cancer cells. And so if BCG works so well, what are some of the adverse effects of it? So a more recent study done in 2021 showed that majority of patients actually really only complain of chemical cystitis as well as bacterial cystitis in several studies. And there are some other ones will be increased frequency, hematuria, but for the most part, patients fairly tolerate BCG really well, with only about 7 to 10% of patients stopping the therapy because of toxicity. And so one of the things that is important to mention or talk about today would be alternative therapies for non-muscle invasive disease. And this is important because for several years now, there's been increase in terms of shortage of the BCG strain that's used in the United States. There's also a lot of patients who do not respond to therapy. So I want to talk about some of the other therapies that we can use for such patients. So BCG strains that's been used worldwide has ranged from BCG Sweden to some in other countries like Russia and Japan. But the most ones that are used in the United States would be the BCG types produced by Merck, the Frappier, as well as the Connert. However, there's been a lot of shortage, mostly because there's really a hard time in terms of producing BCG. It's a bacteria, so it requires a lot of basic microbiology work to produce, and it's really difficult to scale up the production. So Tice is currently the only company in the United States that produces this therapy. And there's been definitely a lot of supply and demand issues. And this has been ongoing since 2019. And it's proposed that this will keep on going for the next 9 to 10 years. So the question is, what then do we do in this age where we are having difficulty with finding BCG strains? So the AU recommendation in terms of rationing BCG is mainly that patients with low-risk disease, there's really no benefits to treating them with BCG. And patients with high-grade T1 and CIS disease should really be prioritized. And they should be prioritized for induction therapy. They should receive the full strength. However, if in the event that this is not available, then we should consider giving them reduced half to 1/3 dose if deemed feasible. In the event that BCG is not available, then we can consider other alternative therapies like mitomycin, although this is also beginning to be some shortage with mitomycin as well. And then other options should be gemcitabine, epirubicin, docetaxel. And I'm going to discuss studies that are been shown to, that has been shown that these therapies work to some degree a little bit further down the line in my talk. And patients with high-risk features, however, who are not willing to take any potential oncologic risk with alternative intravesical agents should definitely be offered initial radical cystectomy, provided they're surgical candidates. And so one of the things that has also been difficult to define in literature is what exactly BCG unresponsive disease mean. And I think a recent study done by Dr. Ashish Kamath at UC Southwestern really led to more standardization of this definition. So essentially, BCG unresponsive is BCG refractory plus relapsing within 6 months. And refractory disease is basically any persistent high-grade disease at 6 months, despite adequate BCG treatment. And this is patients that have gotten the full induction dose of at least 5 doses. And BCG relapsing would be any recurrence of high-grade disease after achieving disease-free state at 6 months. And up to 40% of patients, unfortunately, will fail BCG therapy within 2 years, with some studies showing as high as 60% of patients failing initial BCG therapy. So what should we do for such patients? The AUA guideline states that patients with intermediate or high-risk patients with persistent or recurrent TA or CIS disease should be offered a second course of BCG if they fail the first induction dose. However, in high-grade T1 disease, if they are fit for surgery, those patients should be offered radical cystectomy. If they're unfit for surgery, then they should be considered for clinical trial. And finally, it's important to note that a clinician should not prescribe additional BCG to a patient who has had recurrence disease after 2 induction courses of BCG or induction of plus maintenance therapy. So such patients should definitely be considered for radical cystectomy. In terms of other therapies that are currently being tried for BCG unresponsive disease, one such one will be intravesical gemcitabine, which was a phase 2 trial showed that risk-free survival for patients that got intravesical gemcitabine was 28% at 1 year, with 13 out of the 47 patients that were at risk remaining disease-free at 12 months. And then intravesical docetaxel is another agent that's been studied, and they were able to show that 40% of patients remained recurrence-free at 1 year, with 20 of the 54 initial patients remaining disease-free at 12 months. One study that has continued to gain more and more attention would be combination of gemcitabine and docetaxel when used sequentially. And this actually had really promising data, with risk-free survival being 54% at 1 year and 34% at 2 years. And actually, very recently, I listened to a talk by Dr. Packham at the University of Iowa, where it describes that there's actually been more unpublished data showing that there could be some benefit for gemcitabine and docetaxel for BCG naive disease. And essentially, it's maybe proven to show that it's more beneficial than even starting with BCG. And other therapies that have gained more attention lately would be checkpoint inhibitors, mainly taking advantage of the same immune reaction that I described earlier with BCG, using PD-1 inhibitors, CTLA-4 inhibitors, as well as PD-L1 inhibitors. The most recent one that was approved by FDA would be Pembrolizumab. And so Pembrolizumab get attention with the KEYNOTE-057 trial, where they were able to show that initially, all of the patients that were treated actually had complete response. However, as studies went down the line, they saw that 44% of those initial responders eventually underwent radical cystectomy. And it's also worth considering that there was severe toxicity, with 13% of patients having grade 3 or grade 4 toxicity, including colitis that proved to be fatal in very few of the patients, as well as pneumonitis. Also, the study had a very early endpoint, 36 months, and it's also worth noting that pembrolizumab is definitely way more expensive than BCG or other therapies on markets are. So I think it's really a bit of a heart scratcher in terms of whether pembrolizumab is going to take the place of other therapies in terms of being used for BCG unresponsive disease or even for use for BCG naive disease. In terms of future direction, there's a phase 3 study currently going at UT Southwestern that's been led by Dr. Kamat. And they are actually combining BCG and pembrolizumab for persistent or recurrent high-risk non-muscle invasive bladder cancer. And this study is ongoing with a proposed end date of 2024. And some of the things they're studying would be looking at the 12-month event-free survival, recurrence-free survival, overall survival, as well as toxicity and safety and tolerability of the combined therapy. So I think there's a lot of exciting works happening, and it will be very interesting to see where this new published data goes. And so something I wanted to leave you guys with, just a little bit of something to put in your pocket from this talk, is really just that in patients with high-risk disease, which is usually the ones that we're mostly concerned about, patients that are not fit for radical cystectomy should be considered for intravesical BCG, and they should be getting induction therapy the 6 weeks that I mentioned earlier, as well as 3 years of maintenance followed by surveillance. And for low-risk patients, there's really no benefits to treating them with BCG, but they should still get a single installation of intravesical chemotherapy. And then for intermediate risk patients, those patients should get the same induction therapy as high risk, but they should get 1 year maintenance intravesical therapy. And with that, thank you all so much for listening. I will be opening for questions. And I just have a picture from Chicago where I currently am for my aware rotation. So thank you all so much for your time, and I'm open for questions.
Well, that was a really great review of a lot of different aspects of BCG therapy. It's one of the most challenging areas, I think, just because it's super complicated, and even just down to what the definition of high-risk disease is varies now in the United States and the rest of the world. So I think it's super complicated. Great job. What do you think we can do to try to improve uniformity of treatments for patients with BCG refractory disease? So like what are, because you can see it's incredibly variable from one provider to another, even what people think of as being BCG refractory. There are patients who get multiple induction courses. There are people who get treated with mitomycin or gemcitabine or docetaxel. Like, what do you think the barriers are, and what can we do as a field to try to improve uniformity?
Yeah, so from reading about it, I definitely do agree that there seems to be a lot of differences in terms of what each institution is doing, especially also based on like whatever region you are in the country. So I think this is definitely one of those things where more evidence-based trials will be important, just to show which one of these therapies actually have more efficacy. And I think, for example, with like the gemcitabine docetaxel combination therapy, this was something that in all of my search while I was preparing this talk, I didn't know was used for BCG naive disease. And so there is a lot of unpublished data that's not getting a lot of attention. So I think more conversations surrounding the use of things that have been shown to work in each institution is important. So basically giving more presentations like this, talking about it at like AUA conferences, are I guess some of the things that we can do.
Thank you.
Yeah, well, Omid, this is Isaac Kim. I really enjoyed your talk. I love Chicago, by the way, so you're in a great town. Just a quick question about the BCG itself. In your review of the literature, or again, in preparation for this talk, have you seen any sort of a plans or efforts to actually do something with the BCG supplies? I mean, are they looking for different ways of supplying or manufacturing BCG? Have you come across anything like that?
Yeah, so one paper I came across talked about how they are thinking of bringing strains from different countries. So I think the one they're mostly looking at right now would be the Japan strain. So I think in next few years, hopefully that would be something that would be used in the United States. So there's definitely a lot of talk looking at how well the Japan strain would work in the United States as well.
Okay, thank you.
Ola, fantastic talk, very complicated topic, really well summarized. I just wanted to use this opportunity to give a plug for a lot of work that Pat Kenny has been doing with the Care Signature Council in creating a pathway to help guide the management of non-muscle invasive bladder cancer. He's been working with Nick Strombakis, Joe Brito, some of our residents, and I think that'll be a good instrument for us, allowing for uniform and evidence-based care for non-muscle invasive bladder cancer, especially with the complexities of the shortages and the varying definitions. So that should hopefully be coming around the bend pretty soon, once we get the final approval. And once we do that, we will send it out to the department for everybody to be able to view it. I will be using it readily and happily, and so keep you up to date. But Ola, your talk was very timely given the recent shortages we've been encountering. So thank you for re-educating us on this very important topic.
I think that'll conclude our grand rounds. Olamide, thank you very much.
Thank you.
Everyone have a wonderful weekend.